Good afternoon, everyone, and welcome to our webinar on Mobile Crisis Response Teams, a framework for Ontario. My name is Trevor Timchuk, and I'm the chair of the Communications and Knowledge Exchange Committee for the Provincial Human Services and Justice Coordinating Committee. And today's presenters are Candice Venna and Aaron Piquet of the HSJCC and CMHA Ontario, and Lisa Longworth and Chantal Dupuis of the OPP. Today's webinar is being recorded, and a link for the recording and the PowerPoint will be made available soon afterwards. It will be mailed to you as well if you're registered, and it will also be available on the HSJCC website. We will have a Q&A period following the end of the webinar. You can use the Q&A box at the bottom of the screen. During the course of the webinar, you can put in your questions and we'll get to them in order at the end of the webinar. And there's also a chat box. If you run into any technical difficulties, we'll try to resolve them for you. And with that, I'll turn it over to you, Candice.
Thank you, Trevor. Good afternoon, everyone. Welcome to our webinar. Thanks so much for joining us. Just wanted to kick things off by providing you with a brief overview of what we'll be discussing today. So obviously, we'll start with a background on where this work began and what led us to these great resources. We'll talk about the purpose of this work, particularly what our goals were and what the framework and toolkit do and do not include. We'll then give you some highlights of what's included in both documents. And then talk about some next steps, so what we're looking forward to in the future, and having a discussion with everyone here about what they'd like to see and providing your feedback. So with that, I'll turn it over to Lisa to get things started.
Thanks, Candice. So I don't know if they chose me for the background because I'm the oldest in the group or because I've been around for the project the longest, but either way, I'm thrilled that the release or the launch has happened, and because the work really began in approximately 2019 and was led by a provincial working group of really incredible individuals. I hope that some of them are on here because I can't say enough about their hard work and effort and how valuable their expertise were. So the group came together as folks doing the work or out doing mobile crisis work and developing and refining and implementing teams, or having had done the work for quite some time and they were evolving. And so we came together as folks doing environmental scans on our own and really wanting to come and do some work together to look at some guidance documents that could help us with a common approach and core components. It was the provincial working group was led by CMHA Ontario and the OPP. And we were thrilled when the partnership developed more closely with provincial HSJCC, who were willing to support this work and carry it on with some next steps now, as well as support from the Ministry of the Solicitor General and Ministry of Health, both of whom had representatives on our working group. It's further been endorsed by the Ontario Association of Chiefs of Police and the Ontario Police Associations. And really, while there's been lots of evolution over the last couple of years, and we may touch on that today a little bit, the project scope really started out as mobile crisis response teams being integrated models where police are called to respond to a call involving a person in crisis and are obligated to attend and are attending with a clinician from a local mental health organization or mental health and addictions organization. So when we look at what that amazing group of people look like, they came from all walks across the province. It was very important to us, and certainly Chantal would echo, working and living in the north, that we have representation from all types of communities, urban and rural, all different cultural backgrounds, different police services, different health providers who are out doing the work day to day. So you can read the list there. And we had small police services, large police services, First Nations police, hospital representatives, community health representatives, and government representatives. And then our advisory committee extended to include the provincial various members of the provincial HSJCC. And I also want to give a shout out to their development team or graphics design team who did an incredible job, as well as we had legal support from the OPP or the Ministry of Solicitor General and various other providers from an advisory perspective. And then looking on to consultations, we took the time during COVID, when we all had a little extra time to do some things. We took extra time to really dig deep in our consultations and work with and hear from community groups from the far north, in our northwestern region of Ontario, in our French-speaking communities, in our BIPOC communities, and really digging into what was important. The landscape of police interactions in mental health changed greatly during that time. So we took a step when we needed to and had those difficult discussions, which was really important in the intention of the work. So it provided us some tweaks to do in this project and really pointed us down the road to what comes next, which is exciting stuff.
You'll see in the framework an environmental scan that was completed in 2020, August of 2020. At that time, the environmental scan was completed via survey, and there were 62 teams identified in the framework. We know that there's been significant growth since that time. Just within the OPP, we've seen a growth from 41 teams in 2020 to 60 teams in 2023. So for that purpose, we will be conducting an updated environmental scan to see where the numbers are at now and to help us with refinements and maybe a version 2.0 of this document. Who knows? I'm not making any promises. So the purpose of the framework was to identify really the models that were already in place and those teams that were in development. We wanted to identify promising practices from, of course, all these teams that were already out there doing the great work. We wanted to make, of course, recommendations around what everybody wants to know, I'm sure. The burning question about data. How do we evaluate our teams? What data do we collect? And all of those good data points that will help to prove efficacy. And we wanted to provide a roadmap for police, community health partners, community programs on collaboration and common approaches for programs to develop and improve quality improvement and valuation. What the framework is not intended to do is to prescribe a specific model that is a one-size-fits-all. The framework is not intended to suggest that existing teams need to change their program or the model that they currently have. That certainly is not the intention, but just rather to provide those common approaches, best practices, and share some of the great work that's already in place around the province.
Pardon me, my unmute button was on the other screen. Thanks so much, Chantal, for giving that overview of the purpose. So I'll jump in at this point to discuss a little bit more around the types of models that both Lisa and Chantal have referred to. So in that initial environmental scan that Chantal mentioned was completed in August of 2020, we identified 3 main types of MCRT, Mobile Crisis Response Team models. So the first type was the embedded live response. Embedded live response, and this graphic is also provided within the framework, but just to go into more detail for you all. It includes a police officer and a mental health and addictions worker. And those 2 individuals ride in a police car to an immediate crisis situation. The call typically comes in through 911. And is sent through dispatch to that individual team, and they then respond to the crisis situation. Now, there is the second model, which is the embedded follow-up response, and that again includes a police officer and a mental health and addictions worker who respond together, and they visit someone after the immediate crisis situation has passed, and they do those wellness checks, they do the follow-up, they may refer the individual out to community services wherever possible. And they really just provide that check for that individual who was in crisis. Now, in those situations, typically the referral comes from another officer. It can come from a crisis line, and then that police team, that team with the police officer and the mental health and addictions worker will then respond together. Now, the live co-response is similar to the embedded live response in the sense that it's a police officer and a mental health and addictions worker responding to the crisis situation. Where it differs is that the addictions worker goes in a separate vehicle and they attend the scene when the officer has cleared it for safety reasons. So the officer says, you know, we're all clear, the situation is safe, you can now attend. Again, that request for service goes through 911 to a dispatcher who then dispatches that team. Now, what was interesting in terms of the environmental scan was that what we discovered was that the majority of the teams across the province are some variation of all three of these models. So some even have two different teams within a community where there is embedded live response, and then there is the follow-up response model. So there's a lot of variety around the province. And as of right now, there is no sort of research or guidance to suggest that any of these models are more effective than others, that one is better than another, that one is more effective in a particular context than another. So it really just depends on the community. There we go. So I'll just jump into some initial highlights that we wanted to highlight for everyone today. And I'll start with some of the universal program considerations. So when a community is looking to develop a mobile crisis response team, regardless of sort of the different model, we include in the framework some considerations that every community should really be thinking about as they develop their MCRT program. One of those is establishing the need. So we recommend that communities put together a needs assessment to really be able to think through those initial pieces to establish, like, we do need this in our community, and we would like to proceed with developing one. We also discuss collaboration and partnerships, which are at the center of all MCRT teams. We discuss considerations for First Nations policing, as well as governance. So who is going to oversee the program, who's going to administer the program. We also talk about geography, because of course, across the province, there are some communities where you can have a dense area that an MCRT team would cover. Whereas in Chantal's section of the province, for example, geography can be a factor and a real challenge for some MCRT teams because they're covering a much larger geographical region. We also talk about co-locating, so whether or not the mental health and addictions partner is actually located within the same building or detachment as the police officer, or whether they work out of a separate environment. And then we also talk about the scope of the program. So when teams are just beginning, we do actually recommend that teams provide services for everyone. Once that initial team is in place, communities can look at other options. So more targeted services for youth in crisis or seniors in crisis, or for racialized Black, Indigenous populations, depending on the type of community. But initially, we do really suggest that the service be available to everyone. We also talk about human resources considerations, recruitment, background checks, security is a big one, as well as risk management. And then of course, we always talk about funding and how to secure that and what types of funding might be available. And then we also talk about culture and joint training for both the partner and the mental health addictions worker. So just to go into some of those sections in a little bit more detail for you, some things to highlight in the training and orientation section. One of the things we recommend very strongly is that there are certain contexts where it's really important that a police partner and a mental health and addictions worker partner receive joint training. And an example of that is around privacy, around data collection, around duty to report, around anti-Black and anti-Indigenous racism training. There's a whole list of areas where we suggest and recommend that both partners receive the same information together at the same time. Now, of course, each individual partner has their own requirements under their professional regulatory body, under the legislation. So we do also take into consideration the fact that there is going to be instances where each person has to do training of their own. We also highly recommend within the framework that wherever possible, partners receive training that is offered by clients, by family members, by organizations that work with people with lived experience in order to really get that valuable perspective. And as we all know, we don't know what we don't know. And so this is an opportunity to learn more from other people in that perspective. And then of course, privacy is really crucial. The health partner has, in some respects, different privacy considerations than their police partner may necessarily have, depending on the circumstances. And we get into a lot of those circumstances within the actual framework document. And that's around protecting client confidentiality, as well as sharing information in very specific circumstances where it's relevant to protect each partner and the public if there are safety concerns. Now, I believe I may be turning it over to, is it Candace? It's Lisa. Sorry about that, Lisa.
Thanks, Erin. So the framework also goes into roles and responsibilities, because obviously we're talking about the scope of this particular project from the onset was, as I said, was focused on integrated models with police and mental health or healthcare providers. You know, we really do feel the next step will be to do some looking at civilian-led models, and I know that was one of the questions in the box. So that's definitely the next step. The scope of this was specific to the integrated models, as there's more work that's been done on those at this time. So and in integrated models, there are two very different sectors that are coming together to work and go out on those police calls, and at times mental health calls can be very unpredictable. And so it's really important for, and as Erin said, there's privacy considerations and safety considerations. So ensuring the roles and responsibilities were really unpacked by the whole group was a big focus of this, and we thought it was important to highlight for you. So, you know, having each partner at the scene, the clinician, I'll call them a clinician for the sake of today, could be any, you know, there's many disciplines, but the clinician and the officer. So ensuring that, you know, the officer is there for public safety. That's really their job. And knowing that they're not mental health professionals, we want to have that expertise at the call. So, you know, we cover things like ensuring the scene is safe. That's the role of the officer, before engaging the clinician, to ensure their safety as well. Everybody's safety is of concern in the scenario. Ensuring professional boundaries. You know, ensuring healthcare stays in the healthcare lane and policing are in the policing lane as much as possible. And we're crossing and merging when we need to, and we're signaling appropriately, right? So looking at what mental health supports for each partner, what they can offer at the scene. And to your point, Erin, I thought it was really great that you highlighted the across the lifespan piece, because the role of the police is to go to the call that they received. Right. And the role of the clinician in that, or one of their roles, is to be able to provide service to across the lifespan. Police don't really get to pick and choose that they're going to go to over 18 or under 18 or over 65 or under 60. They're required to provide public safety services across the lifespan. So similarly, when we have an integrated model, that's really important from a healthcare perspective, understanding that a big part of the role of the clinician working alongside a police is to ensure that they have a really solid understanding of community resources to be able to appropriately connect people to senior services that they require, or an assessment, maybe a MOC assessment, or ensuring that they're connected. Maybe it's a family and they're connected to FASD services for caregivers and individuals, so that they're able to go to a call across the lifespan, but ensuring that they're connecting people to the right services based on the individual's needs. So that's I appreciate you highlighting that, and that's definitely in the roles and responsibilities as well. The big thing folks want to know is data collection. What kind of information are we collecting? And to another point in the question, you know, the consultations up front and the ongoing data collection truly needs to have qualitative and quantitative. You know, I come from healthcare, but I work in policing, and we're all very numbers driven because, You know, we need that to fund the programs that we know are necessary in the communities. But it really is important to have that qualitative and quantitative all the way through. And so those are all included in this framework on how to collect those and some suggestions. Because really until we have the numbers consistently across the province, it's hard to prove the efficacy, right? So I work with 60 teams, and I know how amazing the people on those teams are from the health side and the policing side. And I can tell you they're awesome all day long, because that's what I think and that's what I see. But until we have the numbers and the qualitative information consistently across the province, we won't really be able to show that efficacy. So when we get to a place where we're all collecting even the most basic consistent data, that's when we can really dig in and find out, hey, this team works really well, or this type of model like Aaron talked about will work really, really well in this community. And we know that because we've heard from people who've interacted with the teams and we've seen the numbers. And so there is data collection guidance in the document. We leaned into some really, really brilliant folks who I call them data geeks. Like I have some really awesome data geek friends, and, you know, leaning into them, but also leaning into teams that have been existing for quite some time. And they're real experts in this work and have really solidified great data for evaluation. So that was a critical part for us as well that you'll see in the document. So again, to the evaluation perspective, that qualitative and quantitative is important. So, you know, for example, I can say in a program that I'm familiar with, when they offer to do follow-up appointments with the individual, so post-crisis, they have qualitative questions that they invite the individual to answer so that they can get a sense of what that experience was like. And perhaps if they've previously been involved with police and, to another point on the call, not had a great experience or have had a very traumatic experience for whatever reason, what's the difference, right? And so we can start looking at that qualitative piece so we can all do better together. And that is a really critical point towards our overall evaluation, is both the qualitative and that quantitative piece. I'm going to turn it over to Candace to carry on that conversation about community resources and our intersections.
Thanks so much, Lisa. So as Lisa mentioned, obviously the intention of this work was really to focus on those police teams. However, we recognize that there are community crisis mobile teams out there and other resources across the crisis services spectrum. So the framework includes some examples. It's not an exhaustive list, but just some examples that may be helpful for our mobile crisis response teams and police services to collaborate and to really look at leveraging some of those resources in addition to the work that they're doing. Within there, the examples of some of the models, there's also some considerations for other things that are happening within the community. So for example, as per the Police Services Act, every municipality has a community safety and well-being plan. So bringing together police services, health, education to plan better for those in the community. So there's an opportunity there to consider where MCRT teams fall into that planning. There's also situation tables, which provide that immediate support to individuals in crisis. And there may be opportunities where a referral to a situation table may be also appropriate. There are a number of communities that have crisis centers that may provide support in the follow-up to stabilize an individual and to get them the supports that they need at the time. There are also a number of crisis lines across the province, safe bed programs, where again, we're trying to stabilize an individual and getting them the support that they need in the time of crisis. And there are a number of follow-up supports, so peer support-led programs, case management supports for community mental health and addictions, and caregiver supports and victim services. So the second part of the framework really is a great resource to start to provide some of those examples of what is existing. And we know, of course, there are emerging teams and emerging crisis, community crisis response across the province today. So let's move into the toolkit, the second document. This really is the meat of providing some of those templates to support mobile crisis response teams. And I'll just note that a lot of these templates, of course, are adaptable and should be adaptable to your local MCRT needs and your communities, but they're really great resources as somewhere to start. So having that memorandum of understanding between your police services and the healthcare partner, when you're developing a steering committee to help with the development of a mobile crisis response teams, having those terms of reference to be able to adapt for the purposes of your community. The funding proposal. So this is a really great business case to put together what you need to be funded for your mobile crisis response team, as well as a budget template. So will you need ongoing versus one-time costs to support both the police and health partner and some of those administrative costs? There is a data collection spreadsheet, and I know all the data nerds out there will really appreciate having this spreadsheet to help support those efforts. There are some sample job descriptions, so looking at what should be included or some considerations for inclusion of those types of roles for MCRT teams. There's a number of links to training resources, which is fantastic that we spoke about the importance of training for both the mental health and police partners. There is that checklist to go through, and of course, a checklist for police, a checklist for the mental health and addictions worker on what they need to consider on the scene. There is mention of our previous work on the police hospital transition protocols, so really helpful to just follow up on that continuum of care. And there's a little piece on media and communications, because where possible, you obviously want your community to be aware of what you're doing in the service that you provide. So just some guidance on that front. So we've reached the end of the actual content itself, but I wanted to share with you some next steps. So as we mentioned, we are working on an updated environmental scan. There's obviously been a lot of growth in this area since 2020. So looking at those police-led models, but also doing some preliminary research on what community crisis response models have emerged over the last couple of years. We are very much looking forward to having a future forum where we will bring together folks working in these teams across the province to have more discussions on where we're at with environmental scans, talk about where the research is heading, and then opportunities for future work in this area. And we want to have a discussion today with you about what you'd like to see at that forum. And then just looking for ongoing opportunities for knowledge exchange and dissemination of the framework and toolkit. And to Chantel's point, this really is a living document, and maybe there is a version 2 in the future, or maybe there's just an adaptation or whatever the case is, but looking for those opportunities to share what we do know right now to help support those teams across the province. So I guess we can move to the Q&A portion. And I know that there's been a number of questions that have been coming in through the chat. And Snehal, you've been taking note of some of those. So we'll go through the ones that have already come through, but also just keep in mind, and we'll open it up because we have a full half an hour, to where you would like to see further developments in the area of crisis response. And then to my second point around what would you like to see included as part of our discussion for the future planning of a policy forum.
Great. Thanks, everyone. I guess we'll go through the questions that we've received. First of all, one of the questions, just to answer it right away, was answered during this a couple of times. This framework did just look at co-response with police models. So just to answer that quickly. Then I will go through them in order. Did the task force consult people who have been brutalized by police during mental health crisis, or did you consult and engage families who've lost loved ones by police? So I will broaden that to say, did you consult people with lived experience or families of those with lived experience? And I'll say that, you know, just to identify myself as a person with lived experience, not only of mental health, but also of the justice system. You know, I wouldn't say that I was brutalized. I was arrested in what I guess is called a takedown arrest. And it was at a time when police were not at all trained in dealing with mental health crises. And I consider myself very lucky that I was not even injured, let alone worse. Because certainly at that time, especially, that was not the usual outcome. So I consider myself very lucky. I will, however, say that given my mental state at the time, my experience after the initial arrest was not entirely positive. And I'll leave it at that. But so I do understand some of the wording behind this kind of question. So anyway, I'll ask some of the attendees to maybe address whether people who have actually been arrested by police under these kind of circumstances, or families of people who have lost people under these circumstances, were consulted.
Mm-hmm. I think Candace and I can answer that probably. I can speak to the extent of consultations during the process, and then I think Candace can speak to the breadth of which CMHA Ontario is committed to working with individuals with lived experience. In total honesty, we actually identified the need to go back after June 2020 and do more consultation for exactly that reason, after the tragic death of Mr. Floyd in the United States. And so we went back, and even though we had already done quite a bit of peer persons with lived experience consultation through all of the health organizations at the table, because they have the positive relationships and the trust to be able to be open and transparent about their experience and what their thoughts were about what needed to be in here. We went back to the table and worked with several groups, including the Center for Innovation for Peer Support in our consultations. So, and Candace, I think that you can speak to the breadth of which your organization works with police and your experience in everyone's engagement in lived experience.
Yeah, thanks, Lisa. I think on behalf of CMHA Ontario, but also within the work of the HSJCC, we are committed to improving the engagement and experiences of people with lived experience, not just in invitations to participate in certain consultations, but in a meaningful way and in an ongoing way at the beginning of a project, at the beginning of a work, because we recognize the importance of that. We, over the last almost 3 years now, I guess, have been working as a network to help uplift those voices, improve engagement at the provincial level, as well as at regional, local committees, and creating safe spaces for that work. So I'd say we're committed to that. Obviously, moving forward, we are open to hearing folks' feedback on how we can do that in a better way and provide more opportunities for that, because it is so important in everything that we do and in every project that we undertake, that we hear those voices and that we hear them from all across the province and not just from particular areas. And we remove the barriers so that people can participate in those spaces.
Thank you. The next question is regarding older adults in crisis, and I'll read it. As MCRT and COAST programs appear to be engaging with more and more older adults in crisis, and that's based on personal experience in Niagara, is there a current review of developing the mobile crisis response type program for seniors, say something similar to COSS, Crisis Outreach Services for Seniors, as Behavioral Services Ontario no longer is involved in crisis? This space has emerged as a great challenge for current services not necessarily specialized in older adult support, i.e. MOCA.
Yeah, Michael, that's a great question, and I in my years in health, I leaned into BSO many times, and I'm sorry to hear that. I think we touched on it during the presentation that, and I think there's two parts to the answer. One is when police, this project was really based on integrated models where police are called to respond to an individual in crisis, regardless of their age. And as we talked about, that's across the lifespan, right? Police can't pick and choose. That being said, you're right. You're absolutely right. We're also seeing that increase in crisis because our population, our baby boomers are aging. What does my mom doesn't let us say she's the elderly. We're not allowed to say that to her. She doesn't like that. I said, you're a baby boomer, right? And so we're seeing that population grow, and we do need something in place. But I think the other part of that is that, so yes, they can respond to those crises, because if someone calls the police because an aging individual is in crisis, then the police will attend and hopefully take their MCRT worker, because that's a perfect opportunity for them to be involved, and they have the ability to do assessments in the community, and they have the ability to, if necessary, to connect them to the needed senior services in their community and supports, do some safety planning, maybe with caregivers and the individual in crisis, and if necessary, take them to a health facility, right, and have a health-to-health information sharing with the nurses or physicians at a hospital or health facility. That being said, I also think it's important to remember that we don't want police doing healthcare, right? My husband's a police officer. He's amazing, like just amazing, compassionate human being, and would be the first to say we shouldn't be doing healthcare, right? And so we have to, and if we start allowing police to do that, then, the fear, it tips the scales where we want to advocate for healthcare to be doing that work. So I think there's two sides to that answer, and I hope that I've managed to respond and meet the needs from the question. Certainly, if anybody else wants to jump in, feel free.
I would respond to it just from HSJCC, I guess, priority outside of just a crisis response. The HSJCC developed a navigational guidebook for older adults who are involved in the criminal justice system for the very various reasons that you're mentioning here, that for the first time ever, we're seeing more older adults becoming involved in the criminal justice system, interactions with police in the courts, and as well detained within correctional facilities and not necessarily receiving the appropriate supports that they need to meet their specific health conditions. So that guidebook was really to support service providers and caregivers to help support individuals that are older adults who come into contact with the criminal justice system, but also share some best practices for police and other folks that are interacting to see how they can possibly divert and connect. And I'm happy to share that guidebook link in the chat with everyone.
Okay, great. And speaking of guidebooks, these guidebooks that we're discussing today are on the HSJCC website, the framework guidebooks. They're linked actually right from the main page of the HSJCC website. And I think someone also asked about the slides from today's presentation. They will be on the website soon, and everyone who registered to attend today will be sent a link to them as well. The next question is about deaths in custody, and asking if the framework would address basically how to, I assume, how to prevent deaths in custody, police death related to police.
Candace, do you want to start with that one? And I'm trying to, so I feel like it seems to be deaths in custody, so corrections. And I know there's some work underway with CMHA and P-HSJCC. I wonder if you want to speak to that a little bit.
Yeah, I just want to clarify if it's deaths when someone's in custody, like detained by police, or deaths in correctional facilities.
Well, this one specifically says police. although, I mean, they refer to deaths in custody, but then they specify police.
Okay. So I mean, you can do some follow-up with the corrections piece just in case, Candace, so we're fulsome in the response. But I can say that when an individual dies in the custody of police for any reason, an inquest takes, a coroner's inquest in Ontario takes place. And any organization or system involved in that, that were present or accounted for at the time of that death. So for example, perhaps corrections, hospital, police service in Ontario, any party, then the coroner's inquest takes place. And what comes, it's a jury, it's a community-led jury. And they will come, they get to speak to the individuals who testify at the inquest. All those represented or named in the inquest provide witnesses. And then those community members who are on the jury, they provide recommendations. Not the police don't provide the recommendations. Hospital doesn't get to provide the recommendations. It's the Ontarians on that jury that get to make those recommendations. And it is the responsibility of all of those named in the recommendations to respond to those, to action those recommendations. So so I tell you that to say that the work of the mobile crisis response teams are day to day. There are frontline police officers and frontline social workers and nurses going to people's houses when they're in crisis. So the answer to the question is they would not be the ones to address what you've asked. However, the Provincial HSJCC is a great place to bring that information and to look at a more fulsome picture provincially of what could be done. And that's where I'm going to do the pass over to Candace, having explained that inquest process.
Lisa, I just want to add, Candace, sorry, I'll just jump in. I just want to add before you start is that the mobile crisis response teams themselves are a result from a coroner's inquest. So, all police services that, like Lisa mentioned, any organization that was involved in the inquest is held accountable to be responsive to those recommendations. And some of the good work that now has resulted as a result are the development and sustainability of mobile crisis teams in Ontario.
I'll just add, sorry, Candace, I'll just add as well that as Lisa was saying, it is community members from the community in which the individual died. So it's essentially a jury of peers who provide those recommendations. The other thing I'll mention as well is that the recommendations that are the results of a coroner's inquest, I can't speak to how far back you can access them, but they are publicly available and you can get them on the website of the Office of the Chief Coroner. I know for a fact that there are recommendations for any inquest that's been conducted since 2020. After that, I'm not sure if everything was available online yet. But my understanding is that they have committed to continuing to make those recommendations public, and so they get posted on the website of the Office of the Chief Coroner under Coroner's Inquest. So just to add that as well. Sorry, Candace.
No, that's okay. You all covered a lot of what I was going to say. Just on the provincial HSJCC front, I think crisis response has obviously been a priority and continues to be a priority for our collaborative network, and it takes multiple forms. And as we said, we're looking to update the environmental scan. We're looking at the emergence of community-led models. We're looking at all across the spectrum. And our commitment to continue that work will help us to say, okay, where does this model work best in what communities, and how does that support that individual's journey to getting connected to the services that they need? So that is how we're helping to support some of that, and we're committed to doing that work. On the correction side, same thing. We're the Ministry of the Solicitor General, the Ministry of Health, the Ministry of Children, Community, Social Services, and the Ministry of the Attorney General are our 4 partner ministries and sit at the provincial HSJCC. And all of the folks within the human services and justice sector professionals that sit at that table are, constantly identifying new challenges and trends that we're seeing and how we can address them from a provincial lens. So that is our commitment to this work.
I'll just put in my 2 cents, to be honest. I love the fact that people are sounding very supportive of the idea of there being pretty much, from the sounds of it, a second phase to this of going into non-police response models. We are talking about mental health and/or substance abuse issues, and ultimately that's not a police issue usually. And so it does make sense to me that in many cases that, and has been proven in some communities, that you don't need the police to respond at all. And so I am all in favor of us going ahead at some point soon, I hope, with looking into and coming up with ways of encouraging non-police response models. Sorry, that's my 2 cents. The next question is training for police and mental health workers on these teams for trauma-informed and suicide prevention.
I can speak to that, and then anyone else on the panel, if you'd like to add. So as I mentioned, we do provide a full list of possible training topics that we believe each partner should receive, either jointly or depending on their responsibility within the team separately, of course. And one of the things we recommend is trauma-informed care, that be a training topic that each partner receives. Yeah.
Okay, great, thank you. Next had to do with anti-Indigenous racism training. Wondering if Métis elders are included in that.
So I can say we were very involved with several consultations from our Indigenous communities and First Nations police as well. So there were Northern Friendship Centers that were involved in the consultation of the document, but also that's where we received the recommendations for the various training opportunities that are noted in the document. So, so the answer is yes.
And one thing I'll add, Lisa, if that's okay, is that in the actual framework, we do discuss, like we mentioned earlier, considerations around First Nations policing, but also one of the things we do discuss is that in some communities, perhaps what we have referred to throughout the webinar as the clinician partner, in some communities, maybe it's more appropriate for an Indigenous elder or a Métis senator to really be involved in that team. Perhaps in some communities, that is the best approach, and that is the best person to be working with that team. So we did, as Lisa said, we did give that consideration, and it's actually explicitly named and highlighted within the framework document.
I just want to add that I know the Indigenous Police Services in Ontario received some dollars from the Solicitor General's office, specifically for mobile crisis response teams. And I was in a meeting last week with Manitoulin Island in that area, and they've recently hired their own, I believe she was a social worker, and she's working for Tribal Police Service. And so they've taken the money and developed a very unique team that fits and meets the needs of their community. I have spoken with a few other Indigenous police services, and they're all in the process of developing a model that fits best for their service and their communities that they provide service to. So lots of good work in progress now, and we've collaborated and just consulted with one another in recent months, and it's exciting work taking place.
To add to what Chantal is saying, again, we are not prescribing any particular model or structure. What works for your community works best for your community, and we just are wanting to provide the tools and the resources to help make that process a little bit smoother if we can, and to provide sort of that guidance and that support. So again, what works best in your community is what should happen. But we did give that specific consideration for Indigenous communities and for First Nations, Métis, and Inuit communities.
Okay. Yes, I wanted to take note of what someone did say in chat, is that the question was actually referring to Métis specifically, and everyone was referring to First Nations.
Yes,
in the answer.
and I apologize for that.
I want to ask to clarify on people's behalf, because of course those are two different communities.
Yes.
Yeah. And I can say that it's very hard to find to our knowledge, and within in the consultations and the environmental scan through this project, there were no Métis communities identified as having engaged in this work to date. But I think that moving forward, especially as we start to look forward to the landscape of civilian models as well, I think that that's a really important consideration and noted for future reference. Thank you.
Okay, thank you. The next question is actually a series of questions, and we already answered one of them. The second one is a very specific question, and it seems very personal, asking about whether you've witnessed or been in a situation where children or youth have been tasered by police. To be honest, I think that's too personal a question to ask of your own experiences. But anyway, the next question, though, I think is actually quite a fascinating question to ask. So on mobile crisis response teams, who takes the lead? The police or the social worker / nurse, whoever it might be on the human services side?
Chantal has been an MCRT crisis worker, and I wonder if you want to field that one, Chantal.
Sure, thanks for that. It's a great question. So traditionally, I was part of a mobile crisis response team. I have a background in nursing, and I worked as part of the clinician on a mobile crisis team for 2 years. And it really depended on the call that we were attending. So if it was a live call for service, obviously, we would want to make sure, I wanted to make sure that I was safe and that there weren't any weapons involved. And so the police would, and it would lead that call. And just to ensure and ask the person if they were interested in even speaking to me, because it would be surprising to some folks that it's not always, everyone's desire to speak to a crisis worker or to a nurse or social worker. It's unlikely, but it has happened in the past. And so if we were doing a follow-up, if we were following up the day after and the person consented to following up with a mobile crisis team, we would call and tell them that we would like to come out and visit with them. And then I would lead that discussion, and where possible, I'm sitting with the individual, I'm collecting their information, we're talking, we're having a conversation, and where possible and safe to do so, the officers are, possibly outside or in the next room, and they're giving us that space to have a private, confidential conversation. And so it really is dependent, but oftentimes it was me. I have a passion for advocacy, and so oftentimes it was me as the crisis worker, the nurse, in my years of experience. I would lead those conversations, and the officers were happy to sit back because they are the first to say, that's not our area of expertise. Chantal, can you lead these conversations? So I hope that answers the question a little bit.
I'll just add, Chantal, that I think there were two key words that somebody had in that very good question. One was lead and one was authority. And so therein lies the rub when we talk about police calls, police response, civilian response, that kind of thing. The way our legislation currently exists in Ontario is that when police are called to go or when police are called, there is an obligation for public safety and a response. So the authority on those calls does land in the way the legislation is right now. Doesn't mean legislation can't change, but the way it is currently is that police do have the authority on those calls because they have been called to attend them. And so there is a public safety obligation and certain authorities that the police have under various legislations. And however, to Chantel's point, the lead on an MCRT call, often the officer is very much relying on the clinician to do that soft pass and work with the individual through their crisis to reduce risk and get them connected to the right services to meet their needs.
Thanks for adding that.
Great, thank you. In regards to the training for these teams, the next question has to do with peers who have lived experience in mental health and/or addictions, and using organizations like PeerWorks or Center for Innovation and Peer Support, who of course have people who are very experienced in providing training, who have lived experience themselves.
So actually, I'm glad you gave the Center for Innovation a plug, because they were actually part of our consultation group. And I know from working with the teams, at least within the OPP, and I know from working with many of our municipal partners, their health, one of the benefits of having a health partner as you're in these integrated models is the health partner typically has a peer support program and a very active peer support program. And that includes hospitals, right? So we see within the OPP, for example, 70% of our teams are with community mental health organizations who typically have a very robust peer support program, and they can lean into them to your question. And hospitals are more and more having peer support available in their emergency departments. And so that's also something that can be a component of the mobile crisis response team. That being said, we're not being prescriptive. We're just saying that it is typically available. We see that it's typically available, and definitely it was part of our consultation and recommendations within this document. Great question.
I'm aware that we only have a couple minutes left. And so I'm just looking through some of the questions. One person was asking if there's a list of training that people receive on these teams, specifically the mental health workers, what kind of training they get. So I'm just wondering if anyone has any resources that people could be directed to.
Yeah, I can speak to that really briefly, but then Lisa, if you want to add as well. So in the actual document itself, we list a series of recommendations for training, for training, both for the police partner, the crisis worker, as well as what they should do jointly. And so that includes trauma and PTSD, that includes trauma-informed care, that includes anti-Black and anti-Indigenous racism training. It includes training on neurodevelopmental disorders and things like DPIs, FASD. So there's a whole list within the document. I actually have it page 36 and 37 for anyone who's following along. Now, in terms of links to specific training partners and where they can actually get that training, that's included in the toolkit document. There are some ideas there and some links to potential training sources where people can start reaching out for that training if they haven't already received it through their partnerships. I'm not sure if that helps answer the question, but anybody else on the panel, please feel free to add.
And just, I'll do one final question, is actually the last question that was in the box, which I think is actually a really interesting question. The photos that we're using are not only of officers in full uniform, but also the mental health workers wearing bulletproof vests and things like that. Wondering about things, people showing up in plain clothes as a way of reducing stigma.
Yes, so we do speak to personal protective equipment in the document. And this is a very practical question, and it's one, and so I appreciate whoever asked this question. These are all real. I'm reading them all madly because they're great. Every single one of them are great questions. This, you know, we've gone around this one a lot, and we will continue to do that. And it really is up to each police service and health organization. You know, I can say that I've been on both sides of that fence many times. And actually, in one of the consultations we had at the CMHA building with a person with lived experience, all the professionals were, you know, we're all going on and about our opinion, and he was very open and honest and said, you know, I find it interesting, you know, all the sides, and said, you know, I have lived with paranoia as part of my experience for many years, and sometimes I just want you to be honest with me. So there's that side of the coin. There's the other side of the coin where it can indeed, to your question, be very triggering for individuals. And then I go back on the other side of the coin where I hear people who have been involved with these teams and say, it totally changed my perspective of police. And so, you know, there's an opportunity to change minds and have the uniform not be so triggering in the future. So at the end of the day, safety prevails, safety for everyone. And police calls can be dangerous for everyone. And so it's really important for the person experiencing a crisis to feel safe and to be safe. It's equally important for the police officer and for the crisis worker who's going out to be safe. So really it's up to the organizations running the team, the type of model they have, the work they're going to be doing, the scope of the clinician on the calls, and considering safety, personal protective equipment policies and procedures for all of the organizations as well. So, you know, for me, it's safety for everyone. And so, you know, again, I said I have 5 kids. I always say your safety trumps everything else, right? And so safety for everyone's critical. I don't know if anybody from CMHA wants to add something to that, but we do speak to it in the document.
I can say from what I've seen, even of purely civilian response teams in some communities, they of course wear plain clothes, but they actually do wear bulletproof vests with their plain clothes in some cases. So I don't know what you call that. So, you know, safety, but plain clothes at the same time. Anyway, I apologize that we did not get anywhere near through all of the questions, even though we had a lot more time than usual with our webinars for questions. Thank you, everyone, all of our presenters. Thank you, everyone, for all of the questions, a lot of fantastic questions. I'm sorry that we did not get to anywhere near all of them. Again, this presentation will be on the website soon. No pressure to Candace and the Secretariat to get it up there, but it will be available soon. You will hopefully receive a link to it when it does get posted. If you have any feedback, there are the emails for people that you can contact. And thank you, everyone, for attending.
Thank you, everyone.